and welcome to another podcast. Today we're going to talk about chest trauma. Chest trauma is one of those things that obviously has a high level of importance within management of all trauma, and it's actually pretty common across the board as far as trauma conditions go. The main problem associated with chest trauma is the variables that exist in different environments, and often finding studies and recommendations that support practice in those different environments that can give the clinician some assurance that they're actually doing the right thing. So there is a lot of information out there associated with chest trauma, obviously because it has a high prevalence and also quite a high mortality rate, that there's obviously been a lot of research in it and a lot of improvement in practices. Unfortunately, what tends to happen when this is the case is a lot of this evidence gets mixed up and sold to different demographics when maybe it shouldn't have been, or especially shouldn't have been without caveats associated with it. So the goal of today is obviously not to replace protocols or anything like that we have, but just have a discussion about the respiratory system, the thoracic cavity, certain factors that influence its function and therefore can affect its function in cases of trauma, and then have a look at conditions with high mortality rates that we often see, we often talk about, and maybe have a bit of discussion for later reflection on practices that can improve your own personal practice, or at least start a conversation in the right direction. So like all lessons, we'll start with an introduction and we'll have a look at the numbers and a few variables that exist associated with chest trauma. So the numbers sit around 35% of all trauma cases involve the chest. Okay, so considering all the possibilities out there, you'd think that lower limbs or limb injuries would be quite high, but chest constitutes 35% of all trauma, and 25% of all mortalities from trauma comes from chest trauma. The two main mechanisms of injuries, which is no surprise, is blunt and penetration. Now, blunt trauma really outweighs penetrating trauma by a ratio of about 20 to 1. Okay, so 20 cases of blunt trauma to every 1 case of penetrating trauma. Now, if we change the demographic to obviously combat zones, things like that, then obviously we get a lot more penetrating traumas than the average. Okay, so it is demographic or environmentally specific. But across the board, blunt force trauma, mostly associated with motor vehicle accidents or high-speed incidences, is the leading cause of chest trauma. Part of the problem associated with the chest, it is very difficult to get a good assessment, especially in the field, especially with the equipment that is carried by us and carried by the individuals. Layers upon layers of equipment that over the chest, for very, very good reasons, can make it very difficult to do a good chest assessment. Now, don't get me wrong, our training does wonders in providing us means of overcoming some of these barriers, but the difficulty still exists. And in certain circumstances, there's too many variables that actually allow for a decent respiratory assessment in the field. And I think we need to acknowledge that. Now, this complexity of the field and the environments they work in is often coupled with other variables that exist with the human. So human beings not always the same, they don't always fit the textbook. And then also concepts surrounding chest injury and respiratory physiology that may not be understood to the best capacity. Okay, now it's no fault necessarily of the individuals, especially if they're reading something that probably wasn't tailored towards their environment and their demographic. Okay, so this happens, and we'll try to break down a few of these as we go through the lesson. Now, to couple all this, there's certain interventions, in particular needle thoracentesis, that have a high prevalence of fear to perform. So despite its recommendations and all the things that's happened towards needle decompression through thoracentesis, there are still clinicians out there that are apprehensive about doing the actual procedure, doing what's required in order to do a full assessment to look for all the bleeds out of fear of hurting the individual or sticking a needle in somebody that doesn't necessarily needed. So I understand the apprehension, but it's that fear or that inability to trust your own clinical judgment that does unfortunately statistically weigh in the mortality of chest trauma. Okay, so we need to be aware of that. We need to reflect upon that we always have to be comfortable with our own clinical knowledge and our own clinical assessment, that when push comes to shove, we're more willing to make that call. Okay, now reflective practice can assist with that, okay, but obviously exposure to these conditions can also do that as well. So the main goal with all this in play, when we break it all down and we look at these variables in the introduction and what we're tackled with, the main goal is we really need to understand the intent of our management and the intent of our assessments. We also need to understand the variables that exist within our environment, and through reflection, use that to improve the way that we practice. Sometimes if you have a very narrow view on management, especially in trauma, you need to be aware that a lot of the evidence that supports trauma was not made for the environments that we work in. So we need to rely on clinical assessment and reflection in order to improve our practice. So to help in that endeavor, we're going to go through a few physiological considerations to do with the respiratory system before we move into the conditions and their associated management. So to start with, we'll have a look at the respiratory pressures associated with lung ventilations. Now, I know that everybody has an idea about this concept, okay, but we need to talk about it because when it comes to trauma, these concepts really come into play, and when coupled with the ventilation and perfusion mismatch, it actually leads to the clinical manifestations of what we see in trauma. So respiratory pressures and respiratory function relies on pressure differences. So we need to acknowledge that gas moves because of diffusion. Okay, gas itself doesn't have an ionization, so it's not subject to any laws of drift or anything like that. It moves literally from gradient concentrations. So we have an atmospheric pressure that generally sits around 760 millimeters of mercury. Okay, that is the general atmospheric pressure in which we live. Now, obviously, I know variables exist that alters this, okay, but the atmospheric pressure base rate is around 760. When we have a intrapulmonary pressure at rest, so we're not breathing, we're not in any stage of inspiration or expiration, then that is also 760. So it's equal to it, okay, because that's what it does. It moves from a high concentration to a low concentration until we get equal, and then it stops. Now, what needs to be acknowledged is there's also an area called intrapleural pressure, and this pressure has to be, by design, negative to the intrapulmonary pressure at all times. If it is not negative to intrapulmonary pressure, so if it's not less than intrapulmonary pressure, then you have the start of a pneumothorax. And that's what starts a pneumothorax, is a positive pressure in that interpleural space. So when we breathe in, obviously our chest cavity expands, and Boyle's law dictates that the gas will fill the container that it's in. So because of that, if you have a certain amount of volume within your lungs, and then your lung container becomes larger, Boyle's law is going to move that gas that is in your lungs out to fill that space, therefore reducing the pressure. So it drops down to around 757. So 3 millimeters of mercury less, and that itself draws in air from the atmosphere in order to get an equal gradient of its 760. Now, because the pulmonary pressure has dropped, the intrapleural pressure will drop as well to maintain its negative number. And it does that because if it didn't, then there's nothing causing the visceral pleura to be drawn towards the parietal pleural space in order to draw the lungs out. If we didn't have this pressure difference, then the pleural space wouldn't work the way the pleural space does. It would be a pneumothorax, as we spoke about. Okay, so that's the state. We've actually, on inspiration, there's a point in time that we equal atmospheric pressure. And then during normal respiratory cycles, all these recoil stretch fibers relax, bringing down the diaphragm, intercostal muscles, and it increases the pressure within that space. So it's taken the volume of gas that's within the lungs and it decreases it down to 763, so 3 higher than atmospheric pressure, which forces air out, high concentration, low concentration. And the intrapleural pressure goes back to what it was at that resting stage. Okay, so we need to think about this because as we start moving into open pneumothorax or tension pneumothorax, these pressures are going to play a very important role. And if we add artificial pressures to it, and we start considering things like partial pressures of gas, then it's going to play a big role in how much ventilation we're going to give in compensation with our perfusion, which is the next concept that we're going to talk about. So intuitively, everyone that understands the human body knows that air goes into the lungs, it goes into the blood, and that's what gives it oxygen, and CO2 goes from the blood into the lungs, and that's what gets rid of the waste. Okay, so we intuitively know that. But what we need to be aware of is different regions of the lungs have different ratios associated with ventilation and perfusion. So the higher aspects of the lungs, we're talking around the apex, the alveoli sacs are actually quite large, and comparatively it actually has less circulation going to those higher areas than it does in the upper zones. So the actual amount of ventilation perfusion that occurs in those apex region is less than the other two regions. The middle region of the lungs is actually optimal, if you will. It's optimal size for normal ventilation and optimal size for perfusion. So its ratio is the closest together you can get. When we move down to the base of the lungs, our alveoli shrink, so we actually have a lot more alveoli at the base of the lungs, and because of gravity, we actually have a lot more perfusion to that area as well. So there's actually too much alveoli in order for a normal breath to fill, and there's too many vessels and too much blood in order to really compensate for the proper diffusion of oxygen that we need. Now, the reason that's important to know is if we lose certain aspects of our lungs, like if we lose the apex of the lungs, it won't actually have that big of a physiological effect early compared to if we lose the base of our lungs through contusion, pneumothoraces, hemothoraces, whatever it is. If it's at the base of the lungs, we'll actually have larger clinical effects to that. Now, naturally, the body can shunt alveoli. So if there's a situation that the alveoli is not actually receiving enough oxygen to it, so not getting enough ventilation, then the body can shut off that particular aspect of the alveoli in order to compensate for a different area. Okay, and that's called shunting. This can also happen from a pathological point of view, obviously, but it can happen naturally as well. The same thing can happen that if, for example, there's not enough perfusion, there's not enough blood getting to an area, the body has the ability to turn off certain capillary beds with intravessel shunts or valves that basically stop the flow to the capillary beds. Okay, and that will obviously cause what's known as an alveoli dead space. Now, whilst the body can do this in times of needs, it can also happen from pathological regions or trauma reasons that will actually reduce the amount of ventilation coming in or perfusion that occurs. Now, normally speaking, when we're dealing with perfusion, we need to know that we generally have too much capacity at rest. So each red blood cell has around 250 million hemoglobin groups, and each hemoglobin group can obviously carry 4 molecules of oxygen. So we're talking 1 billion molecules of oxygen per red blood cell. And at rest state, by the time oxygenated red blood cell travels around the body and gets back to the heart and lungs, it's used 25% of its oxygen. Okay, so that's all it is used. It's used a quarter of the oxygen it is carrying. And don't get me wrong, not every red blood cell gets filled with 1 billion, but that's its capacity, and the body uses 25% of that. Now, the reason that is important to know, especially when we're dealing with chest trauma, is when we consider how fast a person in trauma can desat and decompensate, we need to acknowledge that what is probably happening is we are dealing with profound ventilation and perfusion mismatch. That sometimes means that we either need to support more perfusion in the case of blood loss or pressure that's associated with that interpleural space, or we need to increase the amount of ventilation pressure that's been occurred through invasive or non-invasive ventilation, because for some reason the ventilation itself is being restricted, whether it's pain, whether it's pressure from the interpleural space. It doesn't matter what it is. We need to know that when someone has symptoms, especially SpO2 dropping, once it gets below that 80 mark, it means that the partial pressure of oxygen within the blood has generally dropped below 40, which means the concentration gradient is no longer there in most cases, which means oxygen will not disassociate and will not feed the tissue. But in order to get to 80, it actually means that the body, through ventilation or perfusion means, has suffered a profound hit, because not even the 75% oxygen reserve that is generally found in red blood cells is enough to compensate for this phenomenon. Okay, so understanding the ventilation and perfusion mismatch and the associations with partial pressures of oxygen can give us a better understanding that a drop in SpO2 is something to consider. And once they get to a certain point, that drop can be profound and have massive and rapid manifestations associated with it. Okay, so let's move away from physiology and let's start linking some of these things to our clinical assessment and our management. So starting with a general approach, we'll look at our clinical assessment. Now, when you first approach a casualty, it doesn't matter if you're using CABCD or if you're using March, primary survey, the approach is similar. We always deal with catastrophic hemorrhage first. In either situation, we always deal with catastrophic hemorrhage first. Now, sometimes that concept gets missed when we're dealing with chest wounds. Everything associated with chest wounds is generally attributed to a respiratory problem, therefore doesn't get taken care of until B or R, depending on the algorithm. Okay, but we need to understand that in some cases, we're dealing with a large amount of muscle mass on the chest, and we're dealing with a lot of vessels that can have some pretty significant wounds that need to be treated. It doesn't actually have any association whatsoever with the actual respiratory function. A classic example of this is machete wounds, knife wounds. People get cut across the chest or the back. You won't have any associated respiratory or breathing problems, but there is a massive hemorrhage problem that is actually quite difficult to control because we can't use tourniquets, and the wounds themselves are quite long and linear that makes quick clot and pressure actually quite difficult. So it is something that should be considered and should be considered in our thought process of how we're going to deal with something like that. Obviously, airway is important. If airway isn't checked and airway isn't clear, it doesn't matter how perfect your lungs are. Okay, they're not actually going to get the ventilation. Okay, so sometimes the problems associated with the respiration obviously involves the airway, so we need to check that, make sure that the ability to get the air in is there. When we're dealing with respiratory and breathing problems, it's always easy to deal with structural damage first. Ask for pain, have a palpation. If they're conscious, ask them to take a deep breath, tell you about the pain, and then do a proper breathing assessment. We look for breathing rate, we look for effort, and we look for depth. Okay, if someone's doing a large breathing rate but very minimal depth, that's usually associated with pain. If somebody's really putting in a lot of effort to their breathing, it can either mean that they're having a lot of problem with ventilation, they have a associated pressure problem within the interpleural space, or they're dealing with some other pathological means that they're trying to increase that ventilation effort, especially in the case of asthma and things like that. So the effort can really help us understand what is going on. Remember, respiratory rate is one of the first things to change as far as the physiological signs for signs of shock. Your breath rate will be the first thing to increase. So if someone has a fast rest rate when they shouldn't, meaning they haven't just come from some sort of high physical activity, it's definitely something that needs investigation. If there's any problems associated with structural damage or your initial breathing assessment, then you auscultate. You have an auscultate right then and there, have a good listen, try to figure out what's going on. Okay, now auscultation is important for pretty much all casualties, but it's just where it sits on the pedestal of importance is the question. Okay. I always recommend, if you notice a problem, investigate further with auscultation because that gives us the good data. Always perform a rub and rake because you've got to look for all those holes, you've got to look for bleeding sites, and you've got to see if those holes are actually associated with the pleural space. Is it an open pneumothorax or is it just a wound on the chest? You need to conduct that assessment. If there is a probability that it involves the pleural space, err on the side of caution and treat it as an open chest wound. As far as monitoring goes, SpO2 really should be considered a must. SpO2, especially in the absence of therapeutic oxygen, is a great tool to use for early signs of decompensation and early signs of ventilation or perfusion problems. Moving on to our first condition, we're going to talk about fractured ribs and flail chest. So this happens, most people are aware that a fractured rib, generally speaking, isn't a big deal. Okay, the person who gets a fractured rib thinks it's a big deal because it's very painful. Painful to cough, painful to breathe, and sometimes long term they can have problems associated with stagnant breathing or associated contusion from the mostly blunt trauma that has caused the fractured rib. So just be aware that other problems can manifest from a simple fractured rib. But when we have a segment of the rib that has been fractured, now textbooks will argue over 2 or 3 ribs, but realistically, if it creates a segment, then it creates a segment. Okay, there was a time period that we called it flail segment as opposed to flail chest. You can see literature on both, it means the same thing. But this is where there's a section of rib that now is independent of the rest of the rib cage. So it is subject to different pressures associated with contraction. So as the intercostal muscles contract, it can pull it in. Okay, it can pull it in. Now what we are told right from the get-go is that you will look for paradoxical breathing. And what that means is as you do, like the picture says here, as they're doing an inspiration is, that segment is sucked in, and as they breathe out, the segment pops out, and that's called paradoxical breathing. Now, in reality, this is actually a late sign, because what happens during the early manifestations of this condition is the intercostal muscles will spasm. And they'll spasm because of the pain. And that spasming of those muscles means that they'll actually hold the ribs in place for a time period. Now, as shallow breathing and as compensation for this pain continues, those intercostal muscles obviously fatigue, and with the associated hypoxia of shallow breathing will lead to that compensatory mechanism not actually being in play, and then you'll get the paradoxical breathing. So if you see it, it actually means it's either a bad flail chest or one that has manifested to the point that the body is losing means of compensation, which means the management needs to kick up a gear. So speaking of management, there's no evidence out there at all that splinting does any good, at all. But there may actually be some evidence, there's definitely some suggestive evidence that says that it causes more harm because of the increased pain and because of the associated stasis that can occur with the lung underneath if the splinting has pushed that actual segment in. Okay, putting more pressure on the contused area, which will reduce the amount of perfusion that is available to that area. Okay, so that's the evidence. So if somebody is naturally holding their hand on that segment because it feels comfortable for them, let them go. But don't get in the habit yourself of trying to splint the segment with padding or sandbags or whatever else you've heard in the past, okay, because the current evidence doesn't actually support that management. What is supported, I should say, is the monitoring of SpO2, the depth monitoring of respiratory effort in particular, and if possible, monitoring of blood gases. Okay, blood gases will get us a really good indication of what's actually happening and how well these people are compensating with this respiratory problem. CO2 is obviously a good indicator. Analgesia is really the management for people with a flail segment. Okay, we need to be careful, obviously, not to sedate them, because the sedation can lead to respiratory depression. Respiratory depression can compound this particular issue because they're already forcing themselves into a pseudo respiratory depression because of the associated pain. So we don't want to compound that. But drugs like fentanyl IV or ketamine IV can be a good point of call for this particular case because it is incredibly painful to move, to touch, to breathe, to talk. Anything causes pain. Sometimes these people are sedated further in order to support them, but on the ground we start with fentanyl and ketamine. And don't be afraid to, especially if you have them for a little bit long term, start using paracetamol, because as silly as it sounds, it actually has shown good synergistic effects, especially when mixed with opioids like fentanyl. Okay, so peroral paracetamol can actually help with the complementary pain relief that opioids bring as well. Fluids pretty much follow the rule associated with all trauma management with fluids. Minimal fluids is best for these people unless they need the perfusion support with associated injuries because of the associated lung contusion. You don't get a flail chest without lung contusion. If you have lung contusion and you put too much fluid in there, that aspect of the lung is more subject to hydrostatic pressure, which means it can lead to APO. Okay, so really minimal fluids is best, but that's generally the rule for trauma anyway. Evacuation is obviously the key for this person. You want to get rid of them as quickly as possible, so early evacuation is a good point of call. Once they get into a higher facility, people can start considering things like regional anesthesia, so I'll actually put in nerve blocks in order to manage the pain, support the ventilation without mixing too many opioids and sedative drugs that can compound the issue. So it's a really good management tool if you have someone that's qualified to do it. Ventilation can be also introduced. You can introduce non-invasive ventilation or invasive ventilation depending on how bad it is, and that could really support that ventilation perfusion status and allow the lungs to be filled a little bit easier than having the person contract. So sometimes non-invasive ventilation can actually support these people because they can ventilate themselves without the associated contraction of their intercostal muscles, which removes the pain. Okay, so it's definitely something that if you're equipped to do so, can be considered. If not, it will definitely be considered in the tertiary facilities. Surgical fix are considered, and we have that rib fixation where they'll actually combine the rib back together and wait for it to heal long term. Okay, so management processes for these people can include surgery and often include support in the facility for quite some time as well. Moving away from our fractured ribs, we'll start a general conversation about open pneumothoraxes. So an open pneumothorax is also called a sucking chest wound, okay, for those that have been living under a rock and didn't make that association. What it means is there's a hole in someone's chest, and that hole has created a portal of entry for the air to come in. Now, an open pneumothorax, generally speaking, is not really subject to tensioning. Now, tension occurs when air can get into the pleural space but has no means of escaping. If there's a hole big enough for air to get in, then generally speaking, there's a hole big enough for air to get out. Now, whilst certain variables exist, like a large body mass or areas associated with lots of flesh or skin, obese people, all these sort of things can make it harder for air to get out, as in the flesh will actually take over the hole, but the hole that was created also included damage of the lung. So whilst it's open into the chest cavity, the hole itself isn't actually an open portal, and the filling of the pleural space is occurring mostly because of the lung as opposed to the hole. Okay, so this can happen. So the presence of bubbles is basically what I'm saying is not always present when you're dealing with an open pneumothorax because of this flesh shifting phenomenon. If there's a flesh shifting phenomenon, or air can't get out, air can't get in because the hole isn't big enough, then you're not going to see the associated bubbling of the site. Okay, so that's not always what you see. Now, you do cover it, okay, because burping the wound is obviously not going to work in this case. And this is also the case that obviously can lead to tensioning, and you'll get signs like subcutaneous emphysema, long-term, all that sort of stuff. Okay, but it can be quite difficult to manage, okay, is the bottom line. Now, if you have a hole in your chest, and generally speaking, that hole is around 2/3 the size of your trachea. Okay, so that is around the 12 mil mark. A trachea is generally about 18 mils, so generally around 12 mil means that air entry, the pathway of least resistance as your thoracic cavity increases, is going to be to enter via the hole in your chest as opposed to the oral cavity down the trachea. Okay, now these people can be encouraged to suck air in as opposed to breathe. Okay, but every time the chest contracts, it's going to bring air in to that pleural space from the atmosphere because it's just pressure gradients. Okay, so we're not really worried about tensioning when there's a true open pneumothorax. We're worried about competition for ventilation and perfusion. Now, obviously, if air enters the pleural cavity, it is useless as far as perfusion and oxygenation goes. It needs to go via the lungs, into the alveoli, into the capillaries before it is viable. So that is the reason that we remove the competition. Okay, it's not going to tension if it's truly open, but it is going to rob ventilation and reduce perfusion as a result of air not going through the lungs. Okay, so that's why we do it. That's why we cover the wounds. Now, covering the wounds is obviously best to do with a vented seal. Okay, but make no mistake, those vented seals are most likely to fail. Big argument out there whether you use vented or unvented seals, okay? And realistically, there's not a lot of evidence supporting the vented seals because whilst in wounds that are created by a knife to be a perfect hole, and then they're treated in that exact same position, the vented seals work quite well. In battle space or in practice, if the wound was created in a position and then we lie that patient down, it no longer works as a vented seal because the body itself has created a seal or a vent. Okay, so it's not a guarantee to work. Okay, so obviously covering the wound, vented seal, caps off, best case scenario, you do it anyway. If you don't have a vented seal, then you can just use a non-vented seal, cover the wounds because the intent is to remove the competition for air entry into the pleural cavity and allow air entry into the lungs themselves. Now, air will build up in the lungs. The fact that it can't get in through the chest does not mean there's not inevitably associated lung injury from these conditions that have put them in this space, which means every time they take a breath in, they're going to leak air out, and if the lung injury itself has created a one-way valve, air is not going to be able to get in to the alveoli, which is often the case. Okay, so they are going to likely move into tensioning from our treatment of seals, vented or unvented seals. Last point we'll mention about open pneumothoraxes is if you have multiple holes on the chest and you place multiple seals on the chest, open all of them. Okay, I don't know where the information about keeping some covered and only one open to have one portal of exit came from. I think it was from when we used three-sided chest seals and we covered the big wound on the back with a full four-sided seal. But there's no evidence or logic to support that notion. We're putting in a one-way valve. So in the probability of allowing these chest seals to work, we want every single probable hole to be able to ventilate out. So keep them all able to ventilate out is basically the message for that one. Okay. Now, management. Oxygen therapy is important. There's a lot of ventilation problem associated with this, and there can be associated perfusion problems because of the increase in interpleural space or intermittent increase in interpleural space as well. Okay, so oxygen therapy is required. Generally keep it around that 94. So you have the SpO2 monitoring. As we mentioned, we use the seal, we give them analgesia, and in this particular case, they're also advisable to give TXA. Okay, so start a TXA infusion as well, and you monitor for early signs of tension. Now, the early signs of tension for an awake person or a person that isn't under a ventilator, basically, is hypoxia, monitoring by the SpO2, and respiratory distress. If you see that, then the first point of call is to burp the wound. Okay, now burping the wound means, when we talk in this space, TCCC has coined it, it means removing the dressing or opening a corner of the dressing, allowing the hole to be open. A good trick can be, is whilst you open that wound and allow for the hole to be open, is to actually move the flesh around on top of the body. If you grab the side of your chest now, you would inevitably be able to move the skin and the flesh over the top of your ribs. Okay, unless you are ridiculously skinny, you will be able to do that. So the same thing happens here, is if you open it up, you don't really see that effect, then you can move the wound around in order to create that link in the hole, if you will, to allow air to exit. If it doesn't work, don't dick around too long. Perform a needle T, which we'll talk about next when we talk about a tension pneumothorax. We need to evacuate these people. These people generally need intercostal catheters and will most likely go into a formal exploration of the lung to see what sort of lung damage there's been, see if the lung tissue is viable to save before the wound is closed up and before they get a chest drain in order to remove that last little bit of interpleural pressure. Okay, the last major one we'll talk about today is obviously our tension pneumothorax. Now, we sort of alluded that an open pneumothorax can become a tension pneumothorax, but it can also happen without an external hole as well. When there is damage to lung tissue, so air is able to leak out the side of the lung, over time, air is going to leak into that pleural space. Now, if the air isn't able to enter back into the same hole of the lungs, which does happen, then it's going to fill up that interpleural space and therefore create a problem. It's going to increase the pressure of the interpleural space. So every time they contract and air inevitably comes down, it's going to be in competition against the pressure that is building up in that interpleural cavity. Now, it doesn't take long. If we remember back the difference between the atmospheric, interpulmonary, interpleural, we're dealing with 3 to 4 millimeters of mercury. That was the difference between those spaces. So it doesn't take much to increase that interpleural pressure in order to create a competition. That means that it doesn't necessarily matter how much we breathe, it's going to inevitably be more difficult because the lung can't expand. Now we will expand on that a little bit further when we talk about different signs and symptoms, but it does make it difficult. The big risk associated with it is over time is variable, is that pressure is going to be so great that it will collapse that lung completely, meaning all ventilation and perfusion from that one lung is no longer there. And the pressure on that cavity will only have so much room that it can obviously expand, and the pressure from that will cause the mediastinum to shift over the other side. And when that happens, it has a kink in the vena cava. And when the vena cava kinks, you get the associated hypertension. Okay, well, that's what we're told. And that is the pattern that we're told about tension pneumothorax. And realistically, it happens, but how quickly it happens and what sort of demographic it happens to is the variable that we need to discuss. So when we look at symptom variation, okay, most people who get tension pneumothorax are ventilated patients. Not in our demographic, you're right, if that's what you're saying, but across the board that influence studies and protocols and things to look out for are ventilated patients. Okay, so they are far more likely to occur in a ventilated patient than they are in a non-ventilated patient. Okay, so that's the first fact that we need to get our head around. When you're dealing with a ventilated patient, you're dealing with a rapid presentation of hypertension. The reason for that is there is no ability for a ventilated patient to physically overrule the amount of air that is sucked in to their lungs or increase that inspiratory pressure themselves based on demand. So it is literally whatever the pressure has been sent to the ventilator will just keep pumping in, and there is nothing stopping the actual outwards pressure being pushed with the lungs into that interpleural space, increasing that interpleural space pressure. Painful, but possible when you're awake, which means you get the kinking of the vena cava, which means you get rapid hypertension. You also get a rapid drop in SpO2 because of the associated profound ventilatory and perfusion mix match. And you are also more subject to see jugular vein distension and tracheal deviation in ventilated patient. Granted, they are late signs, but more likely to be seen. Okay, so that's the most probable patient profile. And you may be thinking that those are the symptoms that you've read, and they're the symptoms that you've been told to look out for, plus or minus maybe respiratory distress. Okay, so that's generally the profile that we're talking about. When we're talking about the non-ventilated patient or the self-ventilated patient, those people that are awake, then we're talking about a very different demographic, a very, very different demographic. Okay, and their presentation is far more progressive. Okay, it's nowhere near as rapid. And the first sign you'll see is respiratory distress. Okay, think about yourself. If you all of a sudden are breathing and then all of a sudden you feel this profound pressure in your chest, that means that you physically need to breathe harder in order to compensate for this pressure you're feeling in your chest. You're going to be distressed as well. Okay, so that's what they show us. Respiratory distress is the first sign. So if someone's in respiratory distress and there's no reason for it, auscultate, find out straight away what's going on. Then you can have associated hypoxemia. Okay, so SpO2 can drop. Hypertension is possible, theoretically, but a very late sign. We mean that there's no way for this person to keep fighting this pressure, no way to keep pushing the interpleural pressure against the interpulmonary pressure. Okay, you're winning the battle, all of a sudden you don't because the pressure's got so great. These people are more subject to subcutaneous emphysema, okay, the bubbles leading up, because you're physically pushing this air into whatever space you can find before hypertension kicks in. things like jugular vein distension and tracheal deviation really do not occur whilst the person is awake. Okay, because by the time you get that, the vena cava has already been kinked off. The vena cava has already been kinked off. They're not awake. You've got tracheal deviation. They're not awake anymore. Okay, they're an unconscious patient at this stage. Okay, so there's the differences that we're talking about when we're looking at a tension pneumothorax. So, which brings in the problem we mentioned at the start, most people don't want to put a needle T in somebody based on respiratory distress. Okay, now that can be coupled to the fact that they've been told that rapid hypertension is actually what they're waiting for. Okay, so you need to start thinking of the two different types of people that these studies and all this information comes from in order to be more confident in your clinical assessment to actually perform the needle T, which we'll discuss next. Okay, so see respiratory distress in someone that could theoretically have a tension pneumothorax, do an auscultation, and fight for the evidence to perform a needle T. That's it. So, which brings us to our management. Remember the catchphrase, hypothesize, identify, and monitor. Pretty much doing what you need to do as far as a tension pneumothorax goes. So we need to theorize patient profiles that could be subject to a tension pneumothorax. We need to be prepared and equipped to identify it early. And we need to constantly monitor cues that will tell us early that somebody is subject to tensioning or has started tensioning themselves. Okay, that's what we need to do. We need to place them in the supine or recovery position unless for some reason they need to sit up like they've got associated airway problems. The reason we do that is because we want to encourage ventilation and perfusion from those lower lobes. If we sit them up, okay, generally speaking, the pressure builds around and we don't actually get as much ventilation as we would if they were lying down. As soon as we identify it, we need to perform needle T. Now this itself brings into a bunch of variables that really need to be considered. And needle T is one of those ones that is subject to a huge amount of study and investigation of what is the right thing to do. And don't get me wrong, TCCC has definitely made leaps and bounds in the right direction, but I still think it's important to talk about certain studies and variables that exist mainstream to see if it can influence our practice as well. The first things to discuss or consider is the positioning of the actual needle T itself. So for many years we were sort of really stuck to the second intercostal space midclavicular line, and in more recent times we've often opened up to the prospects of being able to use the fifth intercostal space on that auxiliary anterior line, which is really useful given the type of work we do and the demographics we deal with. When we're talking about these positioning, most people automatically assume that the fifth intercostal space will be the best point of call as opposed to the midclavicular line. Now, whilst it is easier to find, it does have some considerations, which means when you're evacuating someone and they're wrapped up with things like hypothermia control and monitoring and they're strapped into a stretcher or something like that, they're part of that evacuation packaging case, it can be really difficult to access that needle T in that area, which means subsequent needle Ts in the same regions can be quite difficult in that situation. When we're dealing with considerations associated with the second intercostal space and midclavicular line, then arguably more considerations really come into play. And part of that is tied to the reason that we now use an 8.25 centimeter catheter as opposed to the traditional 4.5 centimeter needle that was used back in the day. So a really large study was done it was basically led by Stevens, and it looked at CT studies of chest walls, and it found that across the adult population, the average size of the chest wall was between 40 and 45 mils. So a 4.5 centimeter needle wasn't going to be successful. Okay, and that was over 50% of the people that actually had a CT. Now, our demographic is generally a little bit larger than the general population, and we also love to do push-ups, which makes our chest wall just that little bit thicker. So we really need that 8.25 centimeter catheter each time. But even with that length, recent studies have showed that even that can be too short. And there's times that it's recommended that if you're using the second intercostal space, you need to go all the way down to the hilt itself. Now, locating the second intercostal space mid-clavicular line may sound easy in theory and may have even been easy for you in practice on the couple of chests that you looked at. But I will tell you that it has a huge rate or a huge association with error in identifying that midclavicular line and that second intercostal space. It is actually more common to misidentify it than it is to identify it, to the extent that during a study, over 60% of emergency physicians misidentified the correct site. Okay, now you may argue that emergency physicians aren't doing needle T, they're going for intercostal catheters. Okay, you could argue that if you didn't want to admit the fact that it is difficult. Because what you have to accept with that demographic is emergency physicians are used to looking at the diversity of humans. They're used to finding and palpating landmarks. Okay, they're used to the way a body feels, and 60% of them still had trouble finding it. So I think we really should consider that it is difficult and admit that it is difficult, and therefore put into practice us checking diverse humans in finding that mid-clavicular line and finding that second intercostal space. Part of the problem comes with people knowing where the clavicle is, okay? Because not all clavicles are created the same, and the angle in which the clavicle travels can often differ as well. So basically it comes down to, we're talking about the midline between the edge of the sternal notch and the acromion process. The midline in between those 2 points is the clavicle. And also you can use the general rule that you do not insert a needle medial to the nipple line. Okay, now that's a general rule, obviously, because when you're dealing with gynecomastia or women with larger breasts, it's obviously going to be inherently different than people that don't have the same variable. Okay, but that's a general rule that you can use for that correct positioning. The size of the needle is very important. We now have a choice between a 14 gauge and a 10 gauge. Now, whilst the 10 gauge is significantly harder to find in our line of work, it is actually recommended by studies to use the 10 gauge as opposed to the 14. Okay, whilst the 14 has routinely been used for a while, there was evidence that was done on quite a large pig model study that demonstrated that the size of the angiocath 14 gauge was not actually big enough lumen to allow the required amount of air to leak out of it before it clotted off or kinked off. Okay, so even when it was put in successfully, then the actual size of the lumen wasn't big enough to relieve a tension pneumothorax to the point that it actually had physiological changes. Now, this was backed up by another study where they looked at 108 different needle thoracentesis that were done by paramedics, and they found only 5% of people actually had improved vital signs in the field. So all these numbers are really stacking up against that. If you are to get it in, and it is to be successful, which is an if, okay, because there was a lot of times that a needle T isn't actually successful based on positioning, especially in that midclavicular line. And then using the 14 gauge was inherent with not releasing enough air before it kinked off to result in only a 5% increase in objective vital signs on the ground. Okay, so these things we really need to take into account. We need to really have a metric to find out whether or not the needle is in, whether or not it's patent, whether or not it's kinked off, and if it actually had the desired outcome. Because if it didn't have the desired outcome, regardless if it got into the space or not, we need to put in a second needle T and then go from there. What really needs to happen is we really need to consider the use of oxygen therapy as well to stay off this hypoxemia. And we need to admit that a needle T is a stopgap. It is a small stopgap when it works. Okay, and that's it. The technique you use it's really up to your training and the time, but in reality, the training has evolved over time that some people were taught to use a angiocath with a syringe on the end of it. The syringe had water, air, or something else in it, and others were taught just to use the angiocath straight. In reality, the positioning and the angle and the insertion into the pleural cavity is the important part. And really, whatever your preferred practice is that meets the intent is okay. Okay, if you were trained a certain way and society's moved around you and what you're doing isn't inherently dangerous and doesn't have any evidence of causing harm, and it's the preferred method you use to achieve the goal, then there's no reason to alter your practice. But if your technique is subpar and there is evidence that it is no longer recommended, then you absolutely need to evolve. Okay, that's all I'm really going to say to that. But the bottom line is a needle T does so much and only has the capacity to do so much. So they really need an intercostal catheter. And if for whatever reason they can't get to a facility that can put in an intercostal catheter, then we need to start a conversation with something that is in between a needle T and an ICC. Now, some of those options have been thrown out there, and they include things like finger thoracotomy and a thoroquick. Okay, both of these are stopgap options, but they both come with inherent risk and skill sets that are required. So when you look at finger thoracotomy, it sounds like a good idea. Okay, and in a lot of cases, it does absolutely relieve the tension of the person. But you do have the associated risk of creating an open pneumothorax. And if you don't have someone on positive ventilation, then you are inherently creating a scenario where air can travel in to the pleural cavity instead of through their lungs, creating the same problem as you had when we were dealing with an open pneumothorax. You also have the problem that if the patient is already in a state within that lethal diamond, and they're in that coagulopathy state or acidotic or cold, and you make an incision, quite a large incision in reality, you have another bleeding site. It is going to be another source of hemorrhage loss. Okay, so these are real considerations that need to be taken into account, and it's not just as simple as making a cut and putting your finger in. Okay, it's a little bit more complicated than that. The thoroquick is a fantastic device, really is. If you haven't looked it up, I recommend looking it up, but it comes with technical insertion. It's more technical than just a needle T. Okay, so it comes with inherent training. So I'm not saying that we're bringing in needle finger thoracocentesis or this thoroquick. I'm just saying that in the event we can't, or in a position where intercostal catheters aren't possible because of our environments, then maybe we should start having a conversation of a stepping stone in between those two in order to provide better care for our patients. Okay, that brings us to the end of chest trauma. Quite a long one, I do apologize. But as you can see, there's quite a lot to cover in chest trauma because there's a lot of evolution in practice associated with chest trauma. And part of that evolution may have crept in a few misconceptions in a couple of people that didn't consider the full picture of our patient profiles or our demographics. So as with everything within medicine or even general practice itself, it is always recommended to question practices, question environments, and truly reflect on circumstances and conditions that we are placed under and see how the evidence that we can find can support us in improving our practice. But until next time, take care.